Good morning, well, good afternoon, and welcome to our Lunch and Learn brought to you from the Gathering Place. Our special guest today is Dr. William Ondo, Director of Movement Disorder Clinics of Houston Methodist Neurological Institute. He has been practicing medicine for over 20 years and specializes in diagnosis, treatment, and research of Parkinson's, essential tremor, restless leg syndrome, and other movement disorders. He also serves as president of the Tremors Research Group. And I am your host, Jeanette Reed. Please use the chat feature located on your screen menu to send questions and comments for Dr. Ondo. Okay. Please mute yourself during the presentation. Our presentation is being recorded. Thank you and welcome, Dr. Ondo.
All right, thank you. Pleasure to be here. Hopefully everyone can hear me all right. So what I was thinking of doing today is maybe a little bit different. The first half of the talk, we're going to get into actually how you create treatments for diseases like Parkinson's disease. We'll, of course, then use Parkinson's disease as an example for this and look a little bit closer at levodopa as how that was developed and how things changed over time. Then we'll talk about some adjunct therapies at the end. I'm not going to get into too much detail about individual drugs and symptoms that they treat, that sort of thing. But obviously, at the end, happy to address questions. Okay. Okay. So, what's a drug? Okay. So a drug is something we consider a small molecule. So, you can draw out the carbons or the sodiums and so forth on a drug, but it has some sort of biological effect. So there's other small molecules that don't do anything to the human body, and they're not considered drugs. But so it's a small molecule. Now, this is in contrast to what's lumped together as a biologic. Now, a lot of new treatments for these days are biologics, and biologics are larger molecules like a protein or an antibody. And probably 3 out of 4 new medicines across the board in the last 10 years have actually been biologics and not drugs. Anything that if you get on commercial that ends with MAB or MIB, those are all antibody type things. Now, that being said, there hasn't been one that's seen the light of day for Parkinson's yet of these biologics, although there have been a number that have been tested and unfortunately haven't been found to be effective. A supplement is usually a small molecule, although that's not necessarily part of the definition. But what makes it a supplement is that it's already in the body, okay? So coenzyme Q is a supplement because your body has coenzyme Q. Levodopa is a supplement, technically, okay? So Cinnamon or levodopa is already in your body, so technically levodopa is not a drug. It is actually a supplement. So some people like that idea. But those are just some definitions of things that sometimes get muddled together. Okay, so how does a drug, and I use this to represent all of them now, how does a drug, come to be? So the first issue is, someone needs to have a problem for which a drug might theoretically help. Then you have to come up with some biologic rationale, and this is where all the basic science research comes in. So in the example for Parkinson's disease, it was early on discovered that there wasn't enough dopamine, so people figured out what the dopamine receptors look like, and then tried to design medicines that could stimulate dopamine receptors, okay? So there has to be some rational base for that. The alternative to that, though, is you might get lucky, and there's already a drug that's proven to be safe that works for something else that might work for your condition too. So a good example of that is actually the Parkinson drugs that were developed for Parkinson's. Turns out that they also treat restless leg syndrome. So ropinirole, which was a Parkinson's drug, pramipexole was a Parkinson's drug, Nupro was a Parkinson's drug. All these things were then repurposed and later actually went on to be FDA approved for treatment of restless leg syndrome. So that's always nice. And as someone in my position, I'm not really a chemist that can develop a new drug, but I certainly have had a hand in repurposing a number of drugs over the years. Then when you have that, then if you have a new drug, you have to go through this huge safety issue, which can take like 8 to 10 years. So animals looking for a variety of different off-label things that can cause problems. And then the last step, the final step in this process is actually testing the medicine on humans. And we do quite a bit of that here, where we always have about, I don't know, 6 to 8 studies going on for new drugs for Parkinson's disease. So it's a pretty long process. This is another way of looking at it. Don't get caught up in this. I just want to make a couple of points for this. Historically, the beginning part of this now, where you're coming up with structuring a molecule to fit a receptor, that has gotten much, much faster with these high throughput assays. Now, you may hear about, AI in medicine. Much of the AI in medicine currently is at this stage because they can figure out the way, in theory, how a molecule is going to look without actually having to make it, just on paper. And then, so this has really significantly helped the first steps of these. The last steps, you still have to do the old-fashioned way. You have to try you have to try these medicines on people and see if there's side effects on people that you're not picking up in the lab and seeing how it works in people. But technology is, in the last 5 years, has markedly increased the first part of this process with computer modeling of these medications. Okay, so again, creating a chemical based on some rational design, repurposing things, and then animal studies, and then finally humans. So when you get to humans, there's a pretty long process involved too. This is sometimes broken down into 4 phases, although these honestly overlap a little bit sometimes. Phase 1 is just pure safety, okay? So often it says you give the medicine, it may not even be people with the disease. It very commonly is med students, okay, that need money. I did a few of these. I have no idea what this is, but you give me $300 and you give the shot, and then you take my blood samples for a week. That was fair to me. I did a few of those over the years. So phase 1 is purely safety of the medicine. Now, phase 2 officially is you're definitely in the disease population. So in this case, Parkinson's disease or tremor. If there's people on tremor, there's studies for tremor as well. But you're still mostly looking at safety and dosing. So phase 2 studies will usually have a bunch of different doses, low dose, middle dose, high dose. And you usually are going to have a placebo group also, because now you're looking at safety in a controlled fashion. Because if you just give everyone the drug and something happens by random chance, you don't know whether it was the drug or random chance. When you have a group that now gets sugar pill, if there's a big difference, if 30% of the people on the drug get a headache and 2% on the placebo get a headache, well, the headache's probably caused by the drug. But you don't really know that sort of thing until you have a placebo group in there. Okay, so phase 2, still looking at lots of safety stuff. If you've been in a phase 2 trial, there's all these EKGs and blood tests every time and stuff like this. But you're also trying to figure out the optimal dose. Phase 3 is the final study. So this is now where you have a bunch of people against a placebo, and you have to prove that it works and that it helps, not just safety, not that it's safe. You're still testing safety. You're always testing safety. But now you have to absolutely prove that it is improving some scale of, in Parkinson's, we have some standard scales, and it has to be better than a placebo, okay? And if you get a successful phase 3 trial, that's when you apply to the FDA, and then the FDA often takes a long time, but they eventually say yay or nay, you can market this drug in the United States of America, and then it's available, okay? Now, a phase 4 trial is after this. A phase 4 trial is a little bit different thing. You have a drug that's already marketed, for example, ropinirole for Parkinson's disease, but you want to test it on restless leg syndrome. So a different population, or somehow very different dosing than it turns out the companies tend to be conservative, so they want the smallest dose that gets you just enough improvement to get FDA approved to minimize side effects, but maybe trying a much bigger dose to see if you can really get more benefit. That would be considered a phase 4 trial. Or an adult drug that is now tested in kids, that would be a phase 4 trial. So that's after the fact, to try to expand the scope that medicine may have use or utility, okay? It's phase 4 trials. But that's how a drug, the general drug process works. All right, now, there's a lot of specifics, obviously, that go into this. You have to have a scale that is going to be statistically evaluated that represents that disease. Now, no scale perfectly represents the whole picture of a disease. Now, in Parkinson's disease, we usually use this thing called this UPDRS, Unified Parkinson's Disease Rating Scale, or you use diaries of how much time the medicine's working versus how much it's not working, global impressions, and then sometimes you do things that are not clinical, like dopamine scans of the brain. Okay, and then there's a whole slew of other things in Parkinson's scales on mood, on energy, on sleep, on cognition, all these different aspects that can be looked at in these. So you need to have a scale that works. You need to know how many people you need to be in the study. Studies are expensive, okay? I mean, it may be $100,000 a person is at the end of the day cost for a study to run this. So you need enough people that you can prove it works. But if you just have thousands of people, it's going to be financially prohibitive for companies to do these studies. So there's statistics that are involved with this. You need, again, you're going to have a placebo group in these studies to get it FDA approved. And usually it's going to be double blinded so that like I, as a researcher, don't know if you're on drug or placebo. You don't know if you're on drug or placebo. That information is available in an emergency, okay, in an emergency, but no one that's directly involved absolutely knows. And then again, there's quite a bit of statistics with this to prove statistically that it's not just random chance, okay? You have the statistics usually are cut off at 5%. So even in a study that's positive, there's a 5% chance that it was just purely dumb luck that made that study positive, okay? But you got to cut that someplace, or you'd never be able to prove anything. So these are all end up based on statistics. And of course, we all know that the greatest liar in the world can be statistics, all right? Then there's, again, a very, very long process with the FDA that goes through the safety data first with animals. I mean, they review these drugs at the animal stage before they give permission to do a phase 1 trial, before they give permission to do a phase 3 trial, and then again at the end of the day. At the local level, when you're actually in a human drug study, there's the investigators like me. There's what I'd like to call the middlemen, the research organizations. I'm not a big fan of research organizations. But they're in between the sponsor, which is usually a drug company, although sometimes it's a government agency. And they make a lot of money in this process. I'll leave it at that. But the idea is so you don't have the sponsor biasing the investigators in any way, okay? And I'm not sure if that really works. There's always going to be some bias in these studies. But the research organizations tend to make studies more complex, longer, because they get to bill more. But I'm editorializing now. And then eventually it goes to the FDA for the final say, yes or no. So it takes a lot of time and a lot of money to get a new drug approved. Okay. So what can go wrong? Well, aside from the drug not working, okay, aside from side effects being too big a problem, there's lots of other things that go wrong too. You may have the best drug in the world, but you can't make it into a pill. So drugs have to be stable in the pill. And a lot of what varies in why this medicine worked great for this other person in my support group, but it didn't work well for me, isn't so much what happens in the brain, but it's what happens in the gut. Because some people just absorb different medicines better than other people. So you have to have, everyone wants a pill as opposed to a shot or an IV. But some drugs, like the biologics, you just can't make those into a pill at all. Okay, those are always going to be IV shots or things like that. So you may have a drug that's not stable in a pill. You may have a drug that's stable in a pill, but it doesn't get absorbed very well. Or if you take food, it won't get absorbed at all. Or if you take other medicines, it gets metabolized in a different way. Or it gets absorbed in the blood, but it doesn't get into the brain because that's a rarefied position. The brain has this thing called the blood-brain barrier, which prevents a lot of junk in your blood from getting into the brain because it would just make you go crazy. So you have to get, in the case of Parkinson's or tremor, you have to get that drug into the brain. And then again, there's all different metabolic, people metabolize things differently. So all these things go into play of whether a drug ultimately will be successful and why there's variability from one person to another. Okay. So let's look at a Parkinson's drug. Okay, we'll start with levodopa. Parkinson's has been around for a while. It was actually probably described in Egypt like thousands of years ago, but it was James Parkinson in 1817 who wrote the official sort of birth of what he called the shaking palsy. And he described slowness and tremor and walking difficulties. He didn't describe stiffness, which is really a key feature of Parkinson's, because actually he never examined any of these patients. He actually wrote this first just from watching people walking around. They weren't his patients, incredibly. He did interview a couple later on and described constipation and sleep problems. But he was an interesting guy. James Parkinson was actually mostly a geologist, and he was the leading geologist in sedimentary rock. That was actually his claim to fame at the time. He was a leading geologist in the world, back when you could be a geologist and a doctor at the same time. His other most interesting thing about him as trivia, he was implicated but never indicted in a plot to assassinate King James II. With a poison dart, actually, at the opera. So he was about to be shipped off to Australia, but because he was someone of note as a geologist, he actually sort of got above it. It was a bunch of his associates. So it's not really clear historically whether he really was involved with the plot or just all his friends were involved with this plot to assassinate the king. So as a total aside from an aside, interesting guy though, James Parkinson. Okay, so when we're talking about treating Parkinson's disease, there's a few different aspects to think of. So most of our drugs that are Parkinson's drugs, quote unquote, symptomatically treat the movement part, stiffness, slowness, tremor, okay? And those are all almost either directly or indirectly are dopaminergic drugs. So these are still thought to treat symptoms. They don't cure. Levodopa doesn't cure Parkinson's disease, okay? It treats the symptoms of Parkinson's disease. And when we're looking at drugs that do that, usually for early Parkinson's, we use this examination, this sort of thing and then walking and stiffness and tremor. And for people already on levodopa, usually we do these diaries because the idea is to make you have more good on time. So people take these diaries at home, how much time is on, how much time is off, how much time is having dyskinesia, how much time is asleep. So those are the scales that we use in Parkinson's for motor symptoms. Now, the whole other aspect of Parkinson's research has been, well, let's treat the underlying disease. Obviously, that's what we all want. That has been very challenging. To date, there's never been a drug which has been proven to help what we call neuroprotection or disease modifying agents. Now, I've been involved with probably 25 studies over the years for this, and we're still batting zero. Now, ironically, yesterday in the New England Journal of Medicine, there was a medicine in a European study that seemed to show some benefit as a neuroprotective agent. It's not a medicine that's available. It's not a medicine that we can use at this point, but that was very encouraging. It was actually similar to the weight loss drugs in the way it worked, okay? So that's in the way that it worked, but it wasn't one of the ones that's available. It wasn't Ozempic or anything like that, but it was in that class of medicine. So just yesterday that was published. So that's exciting news, but it's not something that's going to be an immediate impact on people. So neuroprotection is what we really, really want in Parkinson's disease, but has been very elusive. And then you have other studies in Parkinson's that measure specific things. So again, there's a drug that's FDA approved just for hallucinations. Okay, so that treats the psychosis. There are medicines that are FDA approved for dementia. These are the same medicines that are used for Alzheimer's. They unfortunately are not that spectacularly effective, but they are FDA approved. There's medicines that are tested for constipation and Parkinson's. So these are specific symptoms in Parkinson's, and we do have a few medicines, but most of the time we use medicines that are just, constipation medicines for constipation and Parkinson's, but they're not FDA approved specifically for constipation and Parkinson's disease, but we use them officially off-label, which is fine. There's nothing wrong with using a drug off-label. Okay. Okay, so let's talk about levodopa. So this was one of the most straightforward. It's a beautiful story science-wise if you're a science geek, and I just have a couple of slides on this. So in the 50s, 1951, it was first discovered that something that would later be called dopamine was in the brain. Later on, medicines that were known to block that were shown to reverse or make people actually have Parkinsonism. And over time, this dopamine story, sort of one step at a time, was shown to be very culpable for Parkinson's disease. Okay. Later on in the 60s, for the first time, it was tried that levodopa, which becomes Parkinson's disease, was synthesized in a lab, and then it was given to people. I think it was 67 was the first person that was actually given oral levodopa, 1967. For a few years before, people were getting shots of levodopa, which were never going to be a practical treatment because they only last about an hour. But very, very quickly, much quicker than would be today, within a year, it was such a miraculous treatment for people for which there was no treatment before that it was approved. And then by 69, though, we started to get within a year of it was in people, then we started to see dyskinesia, okay, which is one of the limiting side effects of levodopa. But despite that, being since the late 60s, this has been available, levodopa as a molecule is still probably it still is the most important treatment for Parkinson's disease 60, 70 years later. But there's many, many problems with levodopa, okay? The dyskinesia and the short duration of effect. So over the years, people have been trying to improve levodopa, and there have been improvements with this over the years. So the big problem is you can't give dopamine because dopamine doesn't get absorbed in the gut and it doesn't get into the brain. So levodopa is a precursor to dopamine, but it's a really bad precursor. Only about 5% of that pill of levodopa you take will ever make it to the brain as dopamine. So 95% of that is wasted. So if you could change that even a few percent, that's a big difference, okay? Levodopa also competes with other things. So levodopa is something called an amino acid. An amino acid is what make up proteins, okay? Proteins are made up of amino acids. That's why if you have a protein meal, it can compete with the absorption of levodopa because these other amino acids that are broken down into protein are competing with levodopa to get absorbed. And levodopa doesn't get absorbed very well in the gut to start with, okay? And then the other big conceptual problem is, like I said, levodopa, the body gets rid of it very quickly, okay? Within 90 minutes, most of the pill of levodopa is gone from the blood. So there's all these problems with levodopa and dopamine. And there's just another sketch. I call it the odyssey of levodopa. I mean, you put it in your mouth and it's going to the brain, but it has a long route to get there, and lots of things can go wrong with the levodopa getting to become dopamine in the brain, which is what you want. So over the years, there have been some FDA-approved medicines and some which are in the works to try to overcome these problems. The first one was just a slow-release levodopa. That's still available, okay, generic extended-release levodopa. The problem with that is that it takes a longer time to get going, and it gets unpredictable. It's just a lot less predictable than regular generic immediate release levodopa. I still use generic slow release levodopa, but almost always when we first start it, because when you first start levodopa, it covers up some of these problems. 3 times a day often gets people through the day, but after a few years, that usually doesn't happen anymore, and we usually end up switching the generic slow release to something different. Okay. And again, often just regular immediate release 25/100 levodopa. Now, the other version that's available, that's a pill, is Rytary. Rytary has some immediate release levodopa, and then so it kicks in fast still, but then it also has some slow release levodopa in beads. And we like Rytari a lot. I mean, Rytari does tend to last on average about 50% longer. The problem with Rytari is cost. It's still a brand name medicine, and it sort of waxes and wanes. I mean, one year we don't seem to have much problem getting insurance covered. This year has been horrible getting insurance coverage for Rytari. So frankly, the biggest problem with Rytari is insurance coverage and cost of the medication. The dosing for Rytari, though, if you haven't taken, is very different. And that's another mistake people make, is they underdose it. You actually have to, if you add up the numbers, you have to give about 3 times as much number of Rytari as regular levodopa to get the same peak. The difference is that it lasts much longer, okay? So we like Rytari very much if we can get it covered. At the end of the day, it's levodopa. Again, all these things are versions of levodopa. There is this Duopa pump, which is available, which puts levodopa directly into your gut. It's never been very popular. There's been some issues with it on a technical side, and patients just don't like the idea of having a G tube, a tube in their stomach. It's just kind of, for most people, that's just not something they want. Okay, so it's never really caught on too much, but it has been available for a while. There is this inhaled levodopa, okay, called Inbrija, which is a little bit faster acting. Again, it's levodopa at the end of the day, but instead of going to your gut and getting absorbed, going through that route, it goes right to the lungs, and then the blood picks it up. So it gets absorbed faster, and it's meant for rescue therapy. So it kicks in usually within 15 minutes. Now, it's not meant to be given by itself because it relies on the carbidopa from the levodopa, so it doesn't get metabolized as fast. And then some people do have a hard time. They get irritation, they get cough with the medication. So some people just can't tolerate it. But if you need something to kick in 15 minutes rather than 30 minutes or so with the regular levodopa in a pinch, it's not a bad option. Insurance is always an issue, although we don't seem to have as much problem getting this as we do with Rytari lately. And then there's the stuff in the works that's not quite available yet. There is a new, on paper, even longer acting version of Rytari that's before the FDA right now. It probably will be approved towards the end of the year, maybe even sooner. Again, we did the studies of that. I wasn't too overwhelmed that it lasted much longer than Rytari, but at least on paper it does. And then the newest thing with levodopa that might be available later this year are going to be the sub-Q pumps. So these are pumps of levodopa, or something called phoslevodopa, which becomes levodopa in the body, but it's more stable. And you put a needle just under the skin, and it just infuses levodopa throughout the day. So if you really need a steady amount of levodopa, this is going to be the optimal way to do it. The first one on the market will probably be by AbbVie, and it is before the FDA right now, and it probably, I'm hoping, will be approved towards the end of this year. There's another one by Teva, I'm sorry, not Teva anymore, they sold it. Another one called Neuroderm, which is a little bit farther down the road. But these are infusions of levodopa. You wear a pump like an insulin pump. You have to put a needle under your skin. The needle doesn't bother people as much as you would think. The problem with it is sometimes people do get little irritation over time from the drug, not the needle, the drug, and get little bumps and stuff like that under their abdomen. But for some people, if they're really up and down with the pills of levodopa and you just can't smooth things out, I think that's going to be a nice option. I'm often asked about a patch. Why can't we just have a levodopa patch? Unlikely that'll ever happen. Levodopa is just too acidic, and it doesn't get through the skin in any of the forms that have been tried. People have worked with it, played with it to try to make it get through the skin. It just doesn't. Even though it's not that big a molecule, it's just the acidity, and it chews up skin if you put a patch on there. It gets broken down, that sort of thing. I don't think there's ever going to be a levodopa patch, but these subcutaneous pumps are in the works. And for some people, bad fluctuations, taking 5-6 doses a day of levodopa to stay on, I think they might be a nice option for people. Okay, the Rytari, I'm not going to go into this any detail, but this is, I mentioned, this has this immediate release. I'm going to show some pictures of some of these products. I sort of talked about them already. But this is the longest acting thing we have right now of levodopa. And again, this is just a graph of how much drug is in your body or in your blood, not your brain. Remember, brain is what really matters. We can't really measure brain dopamine minute by minute, but in the blood, you see regular levodopa. It kicks in real fast here, but by 3 hours, it's mostly gone. Okay. With the Rytari, you have this much longer duration of effect. For that you get it in your blood for a longer period of time, but it still kicks in pretty quickly. So that's what's nice about it. This is the inhaled levodopa I mentioned. This is almost pure levodopa, and they formulate it in a way that it becomes really puffy. So if you have, some people in the audience have probably tried Ambrosia, but if you ever, it's a white powder, and if you ever like get a little in the air, it'll just waft in the air forever, okay? Because it's so light. But that's necessary to get the levodopa all the way down the bronchia, all the way into the alveoli of the lungs. Because if it's at all heavy, it'll get stuck on the side of these things. It has to be aerosolized, and that's how they do it. So that's under a microscope. That's actually levodopa, but the analogy is like popping popcorn to make it so it's much bigger and less dense. But that's what the Ambrosia or the inhaled levodopa. This is one of the prototype of I'm sorry, this is the Duopa pump, which has never been very popular. This is just a tube that goes into the stomach. Again, it does work. It works, it keeps you steady on, but people have just often not liked the idea of a permanent tube in the stomach. And these are some of the subcutaneous pumps. This is the one by Neuroderm, what it looks like. And these will just be, just needles that go under the skin. This is the one by AbbVie, which will probably be the one that comes out first. They actually did modify the levodopa a little bit by putting this group. This just is for chemical stability because levodopa in a solution tends to break down. And when you do this, it's more stable. Once it gets into the body, it knocks that section off and it becomes pure levodopa again. Okay. Now, that's what's in the market, what's up to try to make a better levodopa right now. I'll just real quickly mention other ways that we use to augment levodopas. There are other medicines that prevent it from being broken down. So the most important one is the dopa decarboxylase, and this is carbidopa. So, remember levodopa always has carbidopa with it in the United States. In Europe, they use benserazide, which does the same thing. But carbidopa just prevents the body from metabolizing levodopa quite as fast. If you give pure levodopa, it'll last even shorter, and you're more likely to get nausea because nausea is caused in the blood, dopamine in the blood. Then you have these other medicines that prevent the breakdown of levodopa, the MAOB inhibitors, and many of you are familiar with these, rasagiline, which was Azilect, selegiline, which was the first one. It's still a decent drug. And then safinamide, which never really took off because it's more expensive than the others, and it doesn't really seem to be better in any way than the others. And they prevent the body from getting rid of dopamine. And then you have the COMT inhibitors. Entacapone, some of you may have been old enough to know tolcapone, but now we have opicapone. You can tell by the names of classes of medications. Opicapone is more potent than entacapone, also a brand name drug, more expensive. But these prevent the breakdown of levodopa. So hopefully you can see my marker, the mouse here. So what you get is levodopa in the blood. Okay, what you want is over here dopamine in the brain. All right. So the first thing, levodopa can be converted to dopamine in the brain and the blood by these dopa decarboxylase, and this is what carbidopa prevents. Okay. Levodopa can be converted to this other compound called 3-OMD, which is inert, by the COMT inhibitors, and medicines like entacapone and tolcapone block this. So when you block this and block this, more levodopa is pushed into the brain. It is then converted to dopamine, and you want that dopamine to stay around for a long time. The MAOB inhibitors like rasagiline and selegiline, they prevent the dopamine from being metabolized here. And then COMT COMT inhibitors again combine a second time by preventing dopamine from being metabolized. So these are all the way these other medicines are working to try to make the effect of dopamine a little bit longer. Okay. And the other way we can try to have a dopamine effect is to mimic dopamine. Okay, so these are medicines now that aren't dopamine, but trick the body into thinking they're dopamine by binding to the same receptors. And we have dopamine agonists. The advantage of dopamine agonists is they usually last much longer. Okay, the disadvantage is they're not quite perfect, and they tend to have a little bit more in the way of side effects than levodopa. So again, these are drugs that may be familiar to patients: ropinirole or Requip, pramipexole, Mirapex, retigatine, which is Nupro, and then apomorphine, which is a little bit different because apomorphine is a very powerful dopamine agonist, but very short acting. And apomorphine, which by the way has nothing to do with morphine, okay, it's not morphine, it's not a narcotic, it's just the name. It's actually the oldest drug by far of these, invented in the 1800s. But it's a very powerful medicine. And if you look at these drugs, you see here's dopamine here, and then here's apomorphine here. This part of it's identical. Okay, so that's how it tricks the brain into thinking it. The pramipexole has some. They all have these benzene rings, which trick the body into thinking it has the same effect as dopamine. Okay, so these are all other medications. Apomorphine is kind of neat. As I said, this was invented in 1869, but it's not a pill. You can't take it as a pill. So there's shots that have been used for a long time. And then there was this subcutaneous thing that some of you may have been on, Kinmobi, but the company never had enough money for that, and it caused some irritation here, and they basically gave up on it. For some people, it was kind of nice. It was unfortunate it ended. But the latest is there's also going to be some pumps of apomorphine, and they're probably going to come out about the same time as the levodopa pumps. Pumps of apomorphine have been around for a long time in Europe, and for some people, again, they're very, very nice too. So in 2024, there may be a new continuous pump of apomorphine, which is going to compete with the pump of levodopa. I don't know that one's better or worse, but those are the two products that are going to be out in the near future. And here's again, this is before the FDA now, of a pump of apomorphine. Same thing, a needle that goes under your skin and your abdomen, and you wear this pump and you have this continuous stimulation. So just for completeness sake, so I don't show bias, I'm going to list all the other medicines approved. The one other unique class of medicine is istradefylline, which is Nuriance. This is kind of neat in that it works in a different way. It's an adenosine A2A antagonist. I'm not going to get too much into what this is, but in so many words, adenosine A2A receptors are physically with dopamine 2 receptors, and they do the opposite. So in fact, they mutually inhibit the other one. And the body works this way frequently. The body always has something that inhibits something to try to keep everything in the middle, what we call homeostasis. All right. And it turns out if you block these receptors with a medicine like istradefylline or Nuriance, then you actually increase the downstream effect of dopamine. All right. So there are a few of these were tried, but only one of them ever saw the light of day, which is istradefylline, and that is available as a unique mechanism. And then finally, the last drug that's totally different is amantadine, another very, very old drug that was accidentally found to help Parkinson's disease in the 1960s. It was invented as a antiviral medicine, and people that took it for a virus noticed their Parkinson's had got better. So this is then there were phase 4 studies done, okay, off-label effects. And the mechanism for this is still a bit of a mystery. The company talks about this, and it was something called NMD antagonist. That's actually a very minor effect of this. It has multiple effects. We don't know exactly which one treats Parkinson's the most, but it is a unique medicine, and it's used both for tremor in Parkinson's, but also dyskinesia. Gocovri is the brand name version of this, which is a much longer acting, and I will say, honestly, probably more effective medicine than the generic versions, which you take 3 or 4 times a day to get you through the day. simply because, again, it has this long duration of effect with a slow release pill that you take at night. And it's a very nice medicine for dyskinesia. It does have a fair number of side effect issues, such as hallucinations, but for the actual dyskinesia and the off time, it can be very, very good. So if you add up what we have for officially for Parkinson's disease, I actually came up with 23 medicines, some of which are never used or really not available. I didn't talk about anticholinergics, which are other old drugs, which can be very, very good for tremor, but don't help much else in Parkinson's. But you have at least 4 versions of levodopa, the istradefylline, 3 COMT inhibitors, 9 different dopamine agonists, of which really 4 are still potentially used these days. So it actually, if you add it up, there's 23 drugs that have been FDA approved for Parkinson's disease. Okay. The last minute or two, I'm just going to talk about disease modifying, because this is where we've really failed to make much headway. I show this as just to make a point. This is a very simplified version of what's going on in brain cells in Parkinson's disease. And to have a drug that stops one spot, like right here, drugs have been designed to stop this spot. Drugs have been designed to stop this spot. Drugs have definitely been designed to stop this spot over here. It's probably just not going to work, okay? You have to look at it sort of the bigger picture of all these things going on in parallel. So I've become a little skeptical that there's going to be a small molecule that's going to have a major impact in all these things going on. That being said, as I said, just yesterday in the New England Journal of Medicine, there was a drug that seemed to have some neuroprotective effects, but this is probably why we've really failed to have this a neuroprotective drug over the years. There's just too much going on in parallel for one drug with one mechanism to stop the whole process. Okay. And these are just, just a list of some drugs that have been tested and have failed. This is there's 3 times this many drugs that have actually been tested and not shown to be neuroprotective in Parkinson's. I'm often asked about stem cell trials. There are about 3 in the works right now of stem cells where you implant them into the brain. I'm very skeptical of stem cells that go into your blood because they do not get into your brain, and you really need them to get into your brain. So this is just a summary of some of the stem cell things going on. But there's probably towards the end of this year, there will be 3 major stem cell trials of transplants into the brain starting. So that's exciting news. There have been a number of things. Most people have heard of this thing called alpha-synuclein. There have been a number of drugs trying to reduce alpha-synuclein, which builds up in Parkinson's disease, but they have yet to be successful. We participated in one of these. So I think the concept is still there, but right now they're kind of in limbo whether there's going to be another study for that. And then gene therapies, there's different types of gene therapies in the work. There's some gene therapies that just try to regrow to regrow brain cells, okay, things like GDNF. And then there's other gene therapies that are trying to just increase dopamine production in the brain. So we will probably be starting a gene growth gene therapy. These are going to have to be implanted into the brain, so it's a big deal. Okay, not a casual sort of just a pill type of thing. But again, this is nothing is proven to be effective, but this is clearly there are a number of 3 or 4 studies in various stages, probably one of which will start towards the end of 2024 for one of the gene therapy type of things. So in conclusion, I mean, Parkinson's has come a long way. We do have a lot of, compared to other neurological diseases, we do have a lot of, relatively effective medicines to treat symptoms. We have nothing to slow down the underlying disease, and that's where that's the holy grail of Parkinson's right now. We have medicines that treat certain aspects of this, but there's a lot of variability in these medicines, as I try to explain some of the reasons why one medicine may work great on someone and then terrible on someone else. There's a lot of things going on in between people that are different. And usually we just can't predict that as physicians, why, we have the medicine to try, but I can't say 100% this is going to work in you or this is not going to work in you. We just don't know that. Okay, so with that, I hope I didn't get too scientific. I know there were a lot of scientific looking looking slides, but I wanted to both go over some of the meds briefly and a little bit more conceptually about how these things are developed. And I'll see, let me go into my chat and I'll see what's popped up now. And wait a minute, where's chat?
Okay, thank you, Dr.
And if there's
Ondo.
any verbal questions too.
We do have 3 questions from our participants. I'm going to loop 2 of them together because they are related to essential tremor. One of our guests wonders what's next after being diagnosed with essential tremor. And another guest has tremors in both hands, and it's causing concern, especially when cooking and needing both hands to hold a pan. Is there a medication that will help?
Well, yeah, so essential tremor is sometimes confused with Parkinson's disease. It's more what we call an action tremor. So when you go to use your hands, it shakes. So bringing something in your mouth and you shake it. Now that can happen in Parkinson's disease too, but usually the tremor is when the hand is just sitting there and you shake, and it actually stops when you use your hand. So the tremor part of essential tremor is essentially the whole disease, okay? Um, Essential tremor is actually more common than Parkinson's disease, and it varies from trivial to debilitating, depending on the size of the tremor. There definitely are treatments for essential tremor. Okay, I mean the common early treatments are these things called beta blockers like propranolol and nadolol, which so many words block adrenaline, which worsens the tremor. And then the other really common one's called primidone, which was invented for epilepsy, but is used almost exclusively as a tremor drug these days. And then a third medicine that it can be effective but has more side effects to Paramate, which is Topamax, which is most commonly used for headaches, but also epilepsy and weight loss. So those are the most common medicines used for tremor currently. There are a few other medicines that are tried. There's never been a drug that's FDA approved specifically for tremor. Okay, these are all medicines that were invented for something else and then used off label. Other treatments include Botox shots, to actually dampen the tremor by weakening the muscles that are shaking. And then the definitive treatment is surgical. And for people with severe tremor, the brain surgeries are a miracle. Either the deep brain stimulation, which is the same surgery used in Parkinson's, but a different part of the brain, or more recently where they burn a hole in that part of the brain with a focused ultrasound machine. And for the worst of the worst, I mean, those often are 99% effective, but it's brain surgery. It's still a big deal. There's always some risk to brain surgeries. But that's where it stands right now. There are 3 drugs in phase 3 trials for essential tremor, which is nice because, as I mentioned, there's never been a drug invented specifically for tremor. So there are 3 drugs in phase 3 trials and a couple of drugs in earlier stage trial for for essential tremor. And there's even some devices that are being looked at in trials for tremor as well. So there are treatments out there, and hopefully in the near future, there'll be more on the way before having to go to brain surgeries, which are the definitive treatment for essential tremor.
And our last question comes from one of our guests who's already gone through the DBS and is currently taking the Rytary. This guest would like to know if he's confined to a walker forever. This person does exercise 5 times a week.
Well, I'm not sure if I'm going to be able to answer that in any specific way. People that have significant walking problems with Parkinson's often have something else going on too. They may have neuropathy or orthopedic issues. DBS often doesn't help balance very much. It can help the fluidity of walking. It can help the size of the step. It can help the ability to recover quickly if you're going to fall. But in the truest sense, DBS doesn't really help balance. In fact, sometimes it could worsen balance. And sometimes changing the settings can actually improve the balance a little bit as a side effect, lessening the side effect of DBS. We don't really, again, there's 100 reasons people don't walk well. Other things to keep in mind: low blood pressure can sneak up on people as a treatable cause of not being able to walk. So when you stand up, the blood pressure is too low, not getting enough blood to your brain. That's something to keep an eye on. Make sure there's, again, no other treatable issues, orthopedic problems, I mean, there's no reason you can't have that knee replacement. Recovery may be a little slower, if there's orthopedic issues that are contributing to the walking problems. But and then optimizing the Parkinson medicines might help, but like I said, the Parkinson meds don't truly help balance if balance is the reason for the walking difficulties.
Thank you. You've been most informative.